if you have a patient pain, the primary goal is to get rid of their pain. Now, if you can get rid of their pain and improve their function, even better. If you can get rid of their pain, improve their function, and diminish risk of causing problems at other levels of their back, then it has the potential to be a home run.
Welcome back to another episode of the Spine Pod, and we are in NYC.
We are sitting down in New York City with the pinnacle of spine, Dr. Jeff Goldstein. I mean, what an honor and a privilege to be able to sit down with him and have this conversation. Words can't explain it. I mean, really, really, really amazing to be able to sit down with him today.
Can you believe we get to do this?
It's so cool.
It's so awesome. We're in New York. We got to talk to the top of the top in spine surgery. Dr. Goldstein, had such a great conversation with him. We're so lucky.
It's tough to find someone with more experience, has been through more clinical trials and research and teaching and clinical education. I mean, he has done it all. Mm-hmm. And the practice he's built here is absolutely phenomenal. He has patients flying into New York City to come see him. And it's a testament to the work that he does and the clinical outcomes that he has.
I agree. And I feel like he has just the right temperament for a surgeon. As a patient, I loved his philosophy of if surgery is right for you, surgery isn't right for everyone. It should sometimes, and most of the time, be the last option. And that's such an important thing that patients need to hear, and to hear it from someone who is known and, world renowned, really, honestly, in the spine space, I think is amazing.
Well, absolutely right. And he's got this incredible balance of adopting new technologies and listening to data, right? And I think you need both of those things to be able to bring forward new technologies effectively and safely and have good patient outcomes. And he does it so well. He's on the cutting edge, but he's still listening to all the data. I mean, it's incredible the amount of work that he's done over the years, and to be able to sit down with him, I mean, it's a true privilege.
It really is.
Yeah, he's incredible. And I think one of the biggest things for me is the amount of leadership that he shows as well. Across the board, he's done clinical training. I mean, he was integral to the ProDisc process and getting ProDisc to market and working through that training. He is a leader with 3Spine, right, with the MOTUS clinical trial. And he's done it across the board. He does it for patients. He does it for his fellows. Yep. He does it for, other surgeons. It's incredible the work that he does. So to be able to sit down with him here in his backyard in New York City was really special for us, and I'm just so glad that patients get to hear this one.
It was an honor. You get to hear the background noise of NYC happening behind us, the hustle and bustle. But I think we should let them get into this.
Let's jump right in.
Enjoy this episode with Dr. Jeff Goldstein.
Dr. Jeff Goldstein, it is a pleasure and an honor to sit down with you today. Thank you so much for joining us.
Yeah, I appreciate you making the trip up.
Absolutely. Finally, New York City. Yeah. That's a fun one for us.
This is fun. We get to hear all the sirens in the background. We're really here.
Plus, it's Halloween time.
Yeah.
I'm not supposed to say that because now it's not, what do you call it? Green...
Evergreen.
Yeah.
You're giving away when this was recorded.
That's okay. No,
it's true. It's fall in New York.
Yeah, it's a good time to be
pretty.
here. It's a really good time to be here.
It's an exciting time to be here. You guys picked the right time.
It absolutely is. It's perfect weather. Well, we appreciate you taking the time. I think people across the spine industry know you very, very well. So we're not describing you to those folks, but for patients, I want patients to know who we're sitting down with today. You are a leader in the spine industry. You are the director of the Spine Surgery Fellowship here, as well as the education programs here at NYU. You have been the past president at ISAS, one of the biggest meetings, and you have been named Castle Connolly top doctor for about 20 years. You've been identified by Newsweek. You've been identified by Becker's. The list goes on and on. We could sit here for about 30 minutes, but we are sitting down with a true leader in the industry, and it is incredible to be here with you today. I want to bring it back to the start for the folks that don't know you. What was it initially that piqued your interest in getting into medicine in the first place?
You know, medicine is always a challenge. It's an opportunity to really help folks out. And once in medicine, came into orthopedics and then ultimately spine surgery. And it's an area where there's a lot of challenge, a lot of opportunity to really help patients, really have a positive influence on patients' lives. And it's been very, very exciting. I've never looked back. Some days are harder than others, and some patients are more challenging than others. And our results are often very good.
Did you have a point in time where you knew you were going to go into medicine, or would you just think, this is the easiest path for my life? Or what was it that really brought you to medicine?
That wasn't it, Brady. When I went into college, there were a lot of thoughts that I wanted to go into medicine. And when I was in college, a lot of my good friends went into business. I said, well, this looks like a good opportunity. But I missed the part of medicine that it was really challenging to me, really interested me, really provoked my thinking. And I had an opportunity to do some summer work, so to speak, and work on some hospital rotations. And I saw how responsive patients were and appreciative of what they did. And some patients come in, they want your help. I mean, they're sick, they're challenged by different medical issues, and they don't know what to do. And having an opportunity to really help them really is very fulfilling.
We've heard this through point. I think we've heard a lot of this, being able to want to help, but there's this fundamental piece where you're essentially at a place where you can't help yourself, right? I think that's an interesting place to be as a patient. You get to a place where you're in enough pain, some things you can handle on your own. When you get into, back pains specifically, there's nothing you can do other than go to someone who knows what they're doing, right? And there's a lot of conservative treatment options, but I think it's amazing seeing, the folks that come in with kind of that. You always talk about servant leadership, right? I think there's no better way to put that in than dedicating your time and your life to doing something like this.
As you know, there's a lot of people who have back pain, and most people don't need to go to a surgeon for their back pain. That's a good thing. But there are some patients that don't get better with our non-operative treatments, which are, most commonly our the first way we address this. But when they don't get better with non-operative treatments, often there's an opportunity to apply some surgical options. I tell patients sometimes surgery is the last thing on the list. Sometimes it's not on the list at all. But there are some patients that have really benefited.
I think that's changed over time as well. You've been in practice almost 30 years. Was that the same mindset when you started practice of this kind of, we'll start with conservative care and then move into surgical, intervention if needed, or was, the first step of care surgical intervention back then?
No, Brady, I think most of the time it's been non-operative treatment first, because many of these back pain issues will resolve on their own. And sometimes the hardest thing for a patient to understand is, for as bad as they feel, that, hey, my pain may get better. And, just ask them to sit tight, try some non-operative conservative measures, whether it be some therapy, injections, sometimes medications. And I'm not talking about heavy gun medications like narcotics, but even things like over-the-counter medications like ibuprofen or acetaminophen, Tylenol. Those medications in time, quite frankly, really help most patients. But unfortunately, there are some patients that just don't respond to that. They may have weakness, they may have neurologic issues, or just pain that the non-operative treatments just aren't going to cut it.
Absolutely. And so when you look back, so for your undergrad, you went to Colgate, so you were here. Did you grow up here in New York?
Yeah, I grew up on Long Island.
Okay, so you've stuck around here your whole time.
Well, I trained in Cleveland and in Baltimore, but I came back to New York. Never anticipated that I'd be working in New York City, but good opportunities came up, and I came to NYU Langone, and really good place to take care of patients. The facilities have been great, and my colleagues have been really strong, and it's a good group of people to work with.
Absolutely. I mean, the amount of research and the work that you guys do here is incredible. Did you have a time throughout your journey in medicine, when you started med school, did you know, I want to do orthopedics, I want to do surgery, I want to do spine, or was it something along that pathway that drew you to, ortho and spine?
So that's interesting. So I had done some research before I went to med school in plastic surgery. in reconstructive surgery. So I started off in general surgery, never thinking of orthopedics, and wanted to go to general surgery to go into plastic surgery to do trauma and reconstructive surgery. Then I found out that you can go into orthopedics. I was recruited to go into orthopedics when I was in Cleveland. And my thought was, well, I can do orthopedics and then go into plastics, which is a pathway. And then when in orthopedics, I had the opportunity to work with some of the leaders in spine surgery and some of the surgeons in spine surgery who really helped open up the field. And that's what attracted me to go into spine surgery. And here I am, as you pointed out, almost 30 years later.
He loves to do that to people.
That was
you know?
meant to be a
Like,
compliment. That's meant to be a compliment. No, we get these great stories too about how mentorship kind of plays a
Yes,
role
I was
in
thinking the same
people's journey
thing.
in medicine. I think it's fantastic to hear about how most of the folks that we talk to are driven this way because of someone that they trained under.
It's a mentorship. It's really passing it along. I've had mentors before me, and I hope to be a mentor to some of the residents and fellows that I train here. And quite frankly, colleagues mentor each other also. So it's a ongoing giving back.
One of the things that we love about you is your, dedication to research. You've been integrated to research for a long, long time. You've been in that realm. Did you have something that pushed you into research or wanting to do research? Because it's not like your workload is light as it is, right? So you take on research outside of that. And I'm curious what drove you to start getting into the research realm.
There's a lot of questions that we ask we just don't have answers to. And if you don't have the answer, it's sort of driven to find an answer. And that's where research comes in. And, in history, you learn, Santayana said, those who forget the past are doomed to relive it. So we learn from the research that others have done, but then there's questions that are left unanswered. And we created our own research to try to answer those problems.
What we love about you is your dedication to motion preservation as well. And there's a lot of research in that space, and we spend a lot of time in that too. I'd love to kind of hear from a research realm what made you kind of take that direction, and then comparing it to fusion and kind of what you see in the research there.
Early on in my career, we got involved in the ProDisc study, lumbar ProDisc study, and that was the first opportunity for us at NYU Langone to get involved in motion preservation with an artificial disc. And we've had other colleagues here at NYU who have been involved in creating motion preservation devices, but this was a device that came out of Montpellier, France, from Professor Terry Marnet. And we had the chance to do an IDE study, which is an FDA investigational device exemption trial. I think I said that correctly.
You did. I was impressed the way that came out so smoothly.
And we had an opportunity to bring that to our patients. And we have good treatment options for patients with a pinched nerve. If a patient has a pinched nerve in their neck, we can take the disc out. If a pinched nerve in their back, we can take the disc out, take the pressure out. But the motion preservation device, the Lumbar ProDisc, was an opportunity for patients with back pain, which we don't always have a good surgical treatment option for. And so it gave us the opportunity to study these patients, compare them against fusion. And fusion was a good option also, but as by definition, you stop the motion of those discs. So if you have patients who, my orthopedic colleagues have patients they put total hips and total knees in, and they used to, long time ago, used to fuse these joints, but that's not functionally normal. So if you can get rid of the pain and maintain motion, that seems like a great opportunity. So we got involved in the lumbar ProDisc study. We went over to Montpellier, France to train and see some of the patients who had the surgery. And they were very, very happy patients. So then we brought the technology. Well, when I say we, I didn't bring it back, but the investigators brought the technology back to the U.S., and our patients were really, really seeking it out. And we've had good results from it.
Can you speak a little bit more on that? I think that's such a cool experience, when discs really started to come into play. And what did you think when you saw that first disc and comparing it to a fusion? Did you think that it would turn into a big part of your practice when you first saw it? Or were you still kind of skeptical of, I need to kind of see how this moves over time?
I go into new technology. Personally, I'm very open to new technology. Understanding that some technology is going to be beneficial and some isn't, but it's an opportunity to learn from those patients. But when we saw the ProDisc patients, their pain was gone, and they had their range of motion. So I went in with my eyes wide open. I wouldn't say, the proof is in the pudding. We followed these patients for a couple of years out, and the patients had good results. We followed the patients for 6 months, 2 years, and even longer. And patients were doing well, and they maintained their motion. And the promise of whether they would have less degeneration at other levels of their spine, that was borne out. The patients weren't stiff, and they went back doing what they wanted to do. Now, listen, as I said, some patients, we do a lot of fusion surgery too. Quite frankly, probably more fusion surgery than artificial disc replacements. And in the properly selected patients, those patients do very well too. So it's not one size fits all.
Can you go back to those, those early days? So right now we're sitting here and Sentinel, you're talking about ProDisc. Sentinel has put in 250,000 implants, right? They have about a 1% revision rate. I mean, it is a standard of care. They have 2-level approval in lumbar. They have multiple cervical discs. We have 7 and 10-year outcomes data. I mean, really, really, really good data. But when you look 20 years ago, not everybody was on the same page of the adoption of that. Can you talk about what that was like just, as a provider?
Surgeons by nature want to see the data.
Mm-hmm.
I remember once having a professor in orthopedics who said, I don't need the data, I know what works. But something that sounds good and it's funny, but we need data for our patients to show that it works, that that it doesn't put them at risk, that it's going to give them long-term outcomes, that it's worth the cost. So over time, the ProDisc was borne out. We found that the patients had done well.
And you touched on a point too that is one of our favorites. And you brought up this concept that, we have total joints across the body, right? But a lot of folks don't know that we used to fuse knees and we used to fuse hips, right? And if you walked in now and asked, you blew out your knee or you had a bad hip, and the surgeon said, I'm going to fuse you, you'd laugh and walk out of the room, right? What is it that took so long for that adoption in spine that was there, for knees and hips years and years and years before?
Well, for as long as I've been in practice, Brady, I am happy to say that the fusions were done well before I trained. So I can't tell you that by history. But if you have somebody who has, an arthritic knee and you move it, it hurts. If you do a fusion, it stops. But then, you're walking with a very bad posture. It's putting a lot of stress in your other joints in your body. You're putting stress on your hip and on your knee. And the same holds true for the low back. If you want to maintain your motion, if you use multiple levels of the spine, and I don't mean 1 or 2 necessarily, but if you use the entire upper back and the lower back, patients have difficulty doing normal hygiene or tying their shoes, for example. So it's limiting their range of motion. Now I have patients who I do 1 and 2 level fusions on. Some are professional athletes. And they go back to doing that. But I also have patients who have a disc replacement and maintain motion, and they're going back to professional athletics also. But also if they're, normal folks who, have a 9-to-5 job and just want to be with their family, they get back and they're doing without their pain and they're maintaining motion. So it's a win-win.
We talk about that a lot too of, the motion preservation is not just for the folks who are, climbing Mount Kilimanjaro and professional athletes, the folks that are really pushing the boundaries. It's for, the grandparents that want to play with their grandkids, right? And the guy who still wants to golf, and the folks that are doing everyday activities, and the folks that are working every single day and, some of those blue collar jobs. Mm-hmm. Those are the folks that are looking at motion so that they can bend down and pick things up and still operate. It's not just that higher tier.
Patients are so happy when the pain goes away. That's number one. If you maintain their motion, but they still have pain, then you haven't really helped them out. But if you can get rid of their pain and maintain their motion, they get back doing the things they want to do, whether it's athletics or being with their family, they're very happy.
Absolutely. And so you were integral in the ProDisc process and what is all, where it is now. And you actually were a trainer for ProDisc C, I believe, correct? You did some of the training for that?
And the ProDisc C, which is cervical as well as the lumbar.
And so were the clinical outcomes that good that you said, I'm willing to dedicate this time? Because that's a lot of time to go in and do those trainings constantly, right? They're not just one-off trainings.
No, it was a lot of time. We trained people throughout the U.S. and across the globe, and the outcomes were that good. Once again, I hate to, I don't want anybody to listen and say, oh my God, this is a panacea. It's for everything. But when you're doing it for the right patients do well. And it's an exciting opportunity to offer patients new technology that they didn't have available to them in the past.
And I think that's what's exciting about right now is, like you mentioned, sometimes fusion is the right option and it can still be a really good, viable option for patients. But the idea of kind of creating a bigger tool belt or, toolbox of options so that you can see for the patient, this is what's right for you. I'd love to kind of hear your thoughts on that with your work with motion preservation, still doing fusion. Is that kind of how you look at it of I see the patient and then you figure out like what's in my toolbox?
That's absolutely correct. And it's not one size fits all. If you have a patient pain, the primary goal is to get rid of their pain. Now, if you can get rid of their pain and improve their function, even better. If you can get rid of their pain, improve their function, and diminish risk of causing problems at other levels of their back, then it has the potential to be a home run.
One of the things we talk about a lot about too is the fact that, motion preserving devices haven't been around forever, right? So when guys that are later on in their career, some motion preserving devices weren't around, right? All you had was the option to fuse in a lot of instances. Did you have access to any motion preserving options when you were training and just starting practice?
The fusion was the mainstay for a lot of these problems. But motion preservation is around. It was around not with implants. For example, when we have a patient with a microdiscectomy, a patient who has a disc herniation and pain down their leg, that's a motion preservation operation, meaning we take the pressure off the nerve, we take out the herniated disc, and their pain goes away. There's no reason to put an implant in that patient to maintain motion. But the problem is in the cervical spine, for example, when you take the pressure off the nerve or the spinal cord, that can be destabilizing. So you need to provide some stability. And that was always done by putting an implant in or a bone graft between the bones, and then something like a plate and screws or some sort of instrumentation. And quite frankly, it works very well. And those patients did very well. There are patients who have a pinched nerve in their neck. Some patients will just make an incision in the back of their neck, make the tunnel for the nerve bigger, and take the pressure off the nerve. And those patients do well. That's a motion preservation procedure. But in a patient where we have to put an implant in, the only choice we had in the past was to do a fusion. So you need to provide stability, and you need to provide some durability for the procedure. And that's where fusion came in. And when we had the opportunity to do artificial disc or motion preservation procedure, then it got us back to the beginning, meaning to give them the motion they had when they started.
NYU is a teaching hospital, and you spend a lot of times with residents and fellows, and you're teaching them. I'm curious just the mindset that you see of the new surgeons coming, and do they look at motion preservation differently or spine surgery differently than maybe 30 years ago?
For my fellows now, motion preservation has been there as an opportunity for fusion also. So they see both, and they pick and choose what they think is best. For an older surgeon, they may have never seen motion preservation. It's a new technical skill. It's a different way of evaluating a patient. So you have to reset your mind. And you have a procedure that in your mind may have worked very well for your patient. So why change it? But when I train my fellows now and they see, well, listen, if I can achieve the same result and provide greater function for the patient and less risk of adjacent segment degeneration, then why not?
And what are your thoughts on that?
I'm a big fan, obviously, and it's a big fan because I've seen it work for my patients. So as opposed to my fellows who are coming in now who have had the opportunity to read the research, we've had the opportunity to live the research. There's an opportunity by doing the procedure, by studying the data, to see, my gosh, this actually is working pretty well for our patients. So, it's a change in mindset, but some surgeons do it, many surgeons do. For every surgeon, they should do what they're most comfortable with and what works best in their hands for their patients. So it's not necessarily for every surgeon or for every patient.
And I think that's such a good point. And we talk about that a lot too, of that is so important, right? Because you have someone's life in your hands. So, motion preservation has kind of been a slow ship that's kind of been moving. And we're excited because we think it's in a really exciting place right now where there's a lot more options out there for patients. But it can take a long time to change the mindset. Surgeons want to see a lot of that data and research. So what do you think it is about you that you're willing to be kind of at the forefront, a lot of that, the new devices and innovation? What makes you excited about those types of things and kind of diving in?
That's a really good question. And I think a lot of it has to do with a person's mindset of looking at new technology. There are those, some people say you don't want to be first to do it and you don't want to be the last to do it. Most surgeons are probably in the middle. I'm probably more in the forefront in the sense that I don't mind being first, but having said that, I need to know that it's going to be safe for my patients. So it's not like, I'll go to a meeting and have somebody present their data on, the 2 patients they took care of last month and say, I'm going to go try this. But once you see this presented more and more and you see the data, you see 3-month data, 6-month data, 2-year data, 10-year data, I don't necessarily feel that I need to wait for the 10-year data and things like the ProDisc. But when you see that patients are doing well and they're not being put at a higher risk, and it's a procedure that's technically that I can feel comfortable that I can do safely for my patient, then I'm anxious to offer it to them.
Yeah, that calculated risk of saying like, I feel confident in being able to do this, but someone has to be the first one, right? Like there has to be those surgeons at the forefront that are willing to try something new to push the standard of care forward.
You want to make sure that if you're first, that the data is there to support what you're doing.
Of course.
And that there's been good results. And as I said, that it's safe for patients.
One of the things we get really excited about, talking about that topic is as we add new technologies to the tool belt, right? So we have disc replacements, we have lumbar and cervical, plenty of them, tons of clinical data. We now have a facet replacement on the market, right? So we have TOPS from Premia Spine. And you, as you know well, and how we got to know you was 3Spine MOTUS's lumbar total joint replacement, right? So we're starting to get new options. You're on the medical advisory board there. You're the national PI for the study. Can you tell patients about, and they just wrapped up, their clinical study as well, now waiting for data to mature. Can you talk a little bit about the MOTUS device and how it's different than what's on the market right now in terms of motion preserving options?
Well, first of all, as you said, it's a motion preservation device. So in any of these procedures, the first thing you want to do, your primary goal in doing this operation is to take the pressure off the nerves. And by taking the pressure off the nerves, you anticipate that if they have leg pain, that their leg symptoms should get better. Well, if you look at our standard, if you just do a laminectomy, that's a good operation. It takes the pressure off the nerves. Patient will probably wake up and feel better. The problem is that we have data that shows that if patients have instability, what we call a spondylolisthesis, that if you don't stabilize that the long-term results aren't as good, that patients will have recurrent pain and require further operations. So in those patients, we added fusion. And a fusion in 2024 requires instrumentation, which is often what we call pedicle screws, rods and screws, inner body cages, and things that can make more room for the nerve and then stabilize the spine. But it's a fusion. As we said, we've spent a lot of time talking about how fusions, while often needed, aren't, maybe there's something better than that. So then we start getting into things like, you mentioned the Premia device. The Premia device allows you to replace the joints in the back, just like you have joints in your knees, you have joints in your back, we call facet joints, and you replace those joints and allows you to maintain motion. But the indications for the Premia device are very narrow. It's only for a patient with a spondylolisthesis. And we have patients that require stabilization but may not have a spondylolisthesis. So we've moved on from a facet replacement or a lumbar, like a ProDisc, which is a disc replacement. We can offer now total joint replacements, meaning the facets and the inner body disc. And it's a total joint replacement, just like you have a total knee replacement or a total hip replacement. And the indications are much broader. So we can help a lot more patients with that sort of technology, take the pressure off the nerves, facilitate them getting improvement of their pain, maintaining motion, and putting less stress, we'll see, at the adjacent discs.
So like Brady mentioned, you are the national PI of that study. What made you want to join the study and lead it at the same time?
The fellows who invented the disc replacement, Scott Hodges and Craig Humphreys, I've known them for a very, very long time. And they did this the right way. They started off with a concept. They improved the concept as time went on. They started with a very small group of patients and followed those patients. They didn't just say, well, I'm going to do one patient in this hospital and then bring it to the globe. But they followed these patients over time, and they showed that the results were good. They could replicate the results. It was safe, and you can maintain motion. So knowing them, you told me I've been doing this for 30 years. I've probably known them for 25 years. They did this the right way, and that's what I mean by you don't necessarily want to be the first. But this is not being the first in coming into this. This has been done for many, many patients. So while while I'm an early adopter, I have had the privilege of knowing them and seeing their data and knowing that it's really going to help patients.
Which has been a 20-year process, right? So to your point, like this is new technology, but Dr. Humphreys and Dr. Hodges have been working on this for 20 years.
Right.
And it's just now at the point that we're in the US doing a trial, and then you're one of the first surgeons to implant it in the US.
Most people don't realize that when you take something to do a trial on it, it's not like somebody woke up yesterday and said, hey, we should go ahead and try this. I mean, this is like we've said a couple times, it's been going on for years and years. There's a lot of data.
Yeah.
So yes, I'm first, and yes, I'm the national PI, but it's not, I didn't invent this. And, I had the privilege of seeing what they've done and looking at their data. So I've had the opportunity to analyze it, and it's positive, and quite frankly, we're looking at the data. I can speak for my own patients, and our patients have been really happy.
That's great. And I think it's so true. I mean, coming in, this is the first trial I've ever been a part of. And I was really happy to see how much goes into bringing something to the market. We're still in the data collection phase for MOTUS, but like as a patient, any patients listening, you can know that there is a lot of research. There is a lot of, stop gaps that can make something not go to market. It's really, really hard to make it happen. So that, I think, makes me feel a lot better about kind of just medicine as a whole. It's hard to get something new to potentially, implant into patients.
I mean, it becomes a partnership with the government, with the FDA, the Food and Drug Administration. They're very safe. They're very methodical. They're very strict. And this is all good.
Yep.
They're there to protect patients. So it works out very well.
I'm curious. So when you start these clinical trials, the whole goal, like you've said previously, is to get a question answered, right? Or because you think there's some added benefit to the patient. As you look at, MOTUS and a total joint replacement, what is it that has you excited based on, what's not on the market right now and what you can possibly now treat with a new, total joint type replacement?
We do a lot of fusions for these patients, and the fusion, as I said, is often necessary. But if there are some patients that we can provide the same level of safety and the same level of outcome and get them back doing what they want to do, that's a big positive. There are some patients that are having procedure done not necessarily for nerve compression, but because they have discs or joints in their back that are so arthritic that you can't replace them naturally. So, we try things like injections and pain management, et cetera. But if you can replace them mechanically, that's an opportunity to, as I said, for a total joint replacement. We've never had that opportunity before. And if the patients are happy and get back doing what they want to do, it's really nice to see.
Makes your life a little bit easier too, right?
Makes my patients happier. Whether it makes my life easier, that's another discussion.
So one topic we've heard a lot about, and I'm curious what your take is on this. You've seen a lot. You have tons and tons of experience. Having a device like this on the market and its opportunity to possibly change how patients look at care when they enter the care continuum, right? Because I think for a long, long time, and please rebut this if you believe differently, that the word on the street is almost wait as long as you possibly can to get surgery, right? Put it off as long as you possibly can. And we don't see that in other specialties, right? That seems to be pretty specific to spine. Like you wouldn't tell someone with, a brain tumor to wait as long as they possibly can to get surgery, right? You want to get it operated on. Having something like this on the market, do you think it provides patients an opportunity to get into the care continuum a little bit sooner versus waiting for, 5 or 7 or 10 years? What's your thoughts on that?
Kind of similarly to what we've seen with hips and knees, right?
Absolutely.
That brings up a good point. I mean, certainly it's not going to be a first-line treatment for somebody who wakes up with back pain.
Absolutely.
And nor do we are looking to expand the market of patients that have an operation. If patients, I still think that, when we get our results from the MOTUS, we'll be able to talk about that. But I don't see it being, like I said, the first-line treatment. Somebody wakes up with back pain and they know that if they try a few months of non-operative treatment, it can get better and they get back to function, then they don't need an operation. But having said that, if somebody has failed non-operative treatments for however that's defined for that specific patient, and they're still having pain, they're having problems with function, then total joint replacement or the MOTUS device may be a good opportunity for them. They don't have to wait until they're so dysfunctional that they can't work, that they can't spend time with their family, that they're taking narcotics. Those are the things we're trying to avoid. So while surgery is often the last thing on the list, and sometimes it shouldn't be on the list at all, there are some patients who have been, for lack of a better term, discarded because we had nothing to offer them. And now this is an intervention that we can provide earlier to them after they failed the appropriate non-operative treatment. And we'll have to define what that is.
So we've talked about your work in motion preservation. I think it's so exciting seeing all the new devices that are on the market and what's possibly coming down the road. You also do a ton of work in other novel technologies that are gaining massive adoption. You know, we talk about MIS, we talk about robotic type work. First, what are you doing in that realm of kind of new technologies of what's coming to market? And then how do you see those kind of integrating with what's on the market right now and how they integrate with new devices?
You know, initially when I first started practice, we were trying to get the next best screw, different threads, different cages, things like that. And that kind of work is still going on. But you know, we've gotten to the point now that we're pretty good with that. We're looking at new technologies like the MOTUS, like Premia, like disc replacement. But we have enabling technologies, and that's really helped us help a good surgeon be a better surgeon. And there are things like robotics. In 2018, I started to adopt robotic surgery for my patients. And a robot's different in spine than it is, for example, in general surgery. In general surgery, a robot can actually touch the patient and do some of the operation. The robots that we have now in spine surgery actually don't touch the patient, but they enable us to put our instrumentation in the patient more safely, more accurately, less invasively. And I'm a big fan of enabling technologies in that regard, but they also allow us, as I mentioned, to do it less invasively, minimally invasive. And I see opportunities to integrate this kind of technology which is a newer technology, with our even newer technology, things like the MOTUS. We'll get through the study, and hopefully it'll be available for our patients. But then we have to further refine it. And that goes on with surgeon experience and patient experience. And that's what I look forward to doing with something like the MOTUS device, to define which is the best patient for it. You know, we have the patients that were in the fit the FDA criteria for the study, but we'll define that even better. And quite frankly, at some point we may do studies that show us that we want to expand the criteria. And maybe there are other patients that will do even, this will be the best patient for this, or there'll be other patients where I say maybe this is not the best patient for it. One of the hardest discussions that I have with patients in my office is, and I mentioned before, well, surgery is often the last thing on the list. Sometimes it shouldn't be on the list at all. We can't cure necessarily at this point every patient with a back problem with an operation. We're finding more and more, we're better refining which is the right patient for an operation. There are some patients, that may be worse after an operation, and maybe they shouldn't have the operation in the first place. That's the onus on us as researchers and investigators and as surgeons, as physicians, to figure that out. And that's something that's been going on for as long as I've been in practice. It'll be going on well after my fellows are done with their practices. So, but you have the science of spine surgery and the art of spine surgery, and we combine them both, and that's what gives our patients a good opportunity to get good results.
I love that. I haven't heard that before, but I think it is so true. There is an art and science to it, and a little bit of it is especially with innovation, right? That's the art part of figuring out, I have some data, but I have to kind of know and have some art to decide if this is something to keep moving forward and looking into.
I mean, there have been medical devices that have come in the past that have come and gone because time has said, either time has shown that it's not the best device, or quite frankly, they've been made better with newer devices. So here we start with something like a pedicle screw, which has allowed us to get to where we are now with total joint replacement.
I think it's so important too. You talk about this topic of building on the past. We wouldn't be where we are today in spine without both the successes and the failures of what has come before, right? Because that's how you learn through this. You talk about the importance of patient selection, which I think is absolutely paramount. I think another important part that I'd love to hear you touch on is, even surgical approach, right? For some of these devices, because, right now with you look at MOTUS, for example, it's an open midline approach. But I think even the surgical approach will get refined over time to figure out what the best not just what the right patient is, but what the best option is in order to implant that.
I think that's very true because there'll be the opportunity to integrate this with navigation. We use navigation in spine surgery more and more. As I mentioned, we're using robotics in spine surgery. Once we can integrate this technology with our other enabling technologies, we can do the same operation with less tissue destruction, so to speak, or smaller incisions, less muscle involvement, and that'll, as good as the technology is, it can be better.
Can you talk about too, you talk about this, selecting the right patient and finding the patients that do the best. I think what we look at in terms of what determines clinical success has changed over time, right? I think, a lot of times we have looked at radiographic successes, and now that's starting to shift. I mean, you did a presentation on return to work times at Spine Summit last year, right, on the podium. What are some of the new, or how has that shifted over time for what we look at as a clinical success, and are we measuring the right variables, I guess is the right question.
Yeah, you bring up a really good point, because it's not a matter of me telling the patient they did well. It's a matter of the patient telling me they did well. And the patient telling me they did well is because, yes, they have less pain, and that's a pretty easy thing to measure. But if I have a patient who works in a bank and they can go back to work in a few days, or somebody who works in heavy construction and they can go back lifting, in a month as opposed to 2 months, that's get back to doing the things they want to do. That's what a good functional outcome is. Or maybe somebody that's not working side of the house, maybe just taking care of themselves and getting back to their recreational activities. As somebody who likes to get back and go running, or just cross-train or get on their bike. That's what makes patients happy. And, especially if you're a caretaker, whether, you're a mom or dad taking care of your kids, whether you're taking care of your parents. I mean, it's hard to take care of somebody else if you're in pain and can't take care of yourself.
That's absolutely true. And, we talk about this other concept. We've discussed this theory of health economics almost, right? And it's not just a point of care cost. It's what is your cost of, your quality of life and what you can't do up to surgery, or what you can't do after surgery, or what you can do and how quickly you get back to work. And we're seeing a lot more of that as well. I mean, we're seeing employers that are doing direct contracts with hospitals now that are willing to pay for expenses and certain procedures because they've seen the data, right? And it'll be interesting to see how we start to integrate more of those things as well.
If you're a good employee and your boss has to pay, either leaves your slot empty or has to hire somebody to substitute for you, it's economically better for them to get you back in your spot and back at your desk, be more productive, than to have you stay out because you had an operation that maybe, either there was no operation for you, or an operation that kept you out longer than you needed to be. So if you can get back, have a good range of motion, do it through a less invasive approach, and have no pain and be a happier employee, you're going to work harder. So that's the economics of it.
It is. It's really fascinating. And, one of the things we're seeing this now in newer studies as well, is like measuring functional outcomes, right? So you look at return to work, but you also we're seeing wearables data start to come out, right? So that's, how quickly are you getting ambulatory, and not just when are you getting ambulatory, but can you do 1,000 steps in a day or 5,000 steps in a day? And is that a day after surgery or 5 days after surgery? Do you see more of that being integrated into kind of the care continuum?
All my patients want to tell me how many steps they're doing. It's, yes. I mean, this is what patients are looking at. They're looking at their function. They're, back to doing the things they want to do.
I love that. It's like a badge of honor for them. I'm sure to get to come in and tell you, like, guess what? I've done my 10,000 steps.
Especially in New York City, where they, if they want to get someplace, they have to walk.
Yeah.
Go up and down the subway stairs.
Yeah,
that's exactly
well, I mean,
right.
that's a really good point too, of like just the way we live. I live in Austin, Texas, so I sit in a car a lot. I don't have to walk as much, but I imagine a lot of the patients that you see, it just impacts you more based on how much movement that you need to have to live in a city like this. Do you see that kind of impact, like change of like what people are eager for, or how quickly they want to get back to life because of that?
Everybody has their mindset of what they want to do, whether they're in Austin and driving a car. They want to be back and driving the car as soon as they can. Whether they're need to get on an airplane. They want to know how quickly they can get on the airplane. Whether, I talked about going in a subway. Going up and down subway stairs is difficult, especially in a crowded train or in crowded subway, or even going out to see a show or a movie. I mean, if you can't sit for an hour or two during a movie, I mean, you're not happy, your family's not happy. Going out to dinner with your family, things like that, or just playing with your kids. I mean, I have so many patients that come back and say, listen, I've had a patient today. It's like, I don't know if I'm ready for an operation because I got to take care of my kids and I need to get back to them quickly. These are all normal things that people do. And if you're in pain, you can't do it.
I think we see that a lot, and it's fascinating on this topic of patients. I think a lot of times when we think about new technologies or what's coming to market, we think about almost a top-down approach, right? So what industry is providing or what industry is creating or what surgeons are creating, and that gets provided to patients. I think we're getting into this realm where patients have access to more data, right? And they have access to more information. In your many years of practice, have you seen what patients are now requesting? Has that changed over time? Do you have patients that are either demanding certain procedures or asking for certain things when they come in that they may not have been before? Has that changed over time for you?
Well, sure. I mean, patients are asking for things like motion preservation. They're asking for minimally invasive procedures. They don't necessarily know what they are, but we can explain it to them. I mean, listen, I tell patients that a minimally invasive procedure has to be maximally effective, or patients are minimally understanding. I almost get the impression sometimes a patient will think a minimally invasive procedure means we're not making an incision. But there's always some incision. It could be the size of a pencil. But if you don't get the job done, patients aren't going to be happy. I mean, I've done revisions on some surgeries that patients have had done at other places, and they come back and it's like, well, you still have pressure on the nerve, and that's why you need to, we need to do a revision, or it wore out or something of that nature. So, a lot of it is, patient demand, but also we need to educate the patients too.
I think that's a very important point. Can you talk about, for patients that are looking for this information, right? There is access to so much information. It's almost, one, it's overwhelming, but two, how do you know that you're getting the right information? Yeah. When patients are coming in, what should they be asking for? How should they be asking questions? What does that process look like?
Well, first, when a patient comes in, you need to have a diagnosis. So a patient comes in, you get your imaging, you do your physical examination, and you come with a diagnosis. Some patients come in and they've had a couple of days of back pain, and they ask you about a procedure. It's like, you're getting ahead of yourselves. Let's sit there and try to help you get rid of this pain. And patients, need to have a level of comfort with their physician. Oftentimes, it's because they've been referred by their primary physician or another surgeon or Dr. Google. They have to be careful what they read online. There are some patients who have a lot of back pain and they just can't sleep at night, so they're sitting there doing the blogs. And, that's one patient's experience that may or may not have had an operation. And it's often misinformation, and you don't know anything about that patient, why they have pain, what their stresses are in their life, if they got an accident or whatever it is. So it's you have to be able to tease that out of what you read on the internet. And the best thing is to talk to your physician, and your physician should be able to lead you in the right direction. And patients get other opinions too, which I never discourage.
I think that's such a good point. And we talk about that. Like, it's so great that there is more access to information out there, especially when, in spine care, we're like, there's room for innovation and pushing the standard of care forward, which is why we're excited about the potential of MOTUS. So it's good that patients have the ability to, they can push the industry forward too with what they demand, but it's so, it's a delicate dance because there's also a lot of misinformation, or just because your cousin was perfectly fit for one thing doesn't mean that that's exactly right for you. And how do you talk to a patient that's like, comes in and is like, I found this exact thing that cousin Susie said was perfect for her, and I want this, and you can't change my mind?
Well, I laugh because that's not uncommon. It's like, I know cousin Susie; she had the same problem, and typically my response is, well, I hope cousin Susie's doing okay, but it may or may not have been the same problem.
Yeah.
And and I'll discuss with my patients how your history, your physical examination, the imaging, the pieces of the puzzle really need to fit together. And in my experience, those are the patients that do best with a surgical procedure, if in fact I offer them one. So, as I've said before, while surgery is often the last thing on the list, sometimes it shouldn't be on the list at all. But in the properly selected patient, the properly educated patient, the properly motivated patient, and there are other things to consider also. If I'm offering a patient surgery, it's because I think that it's going to be, the benefits will outweigh the risks.
It's a fascinating talk track to go down that. Do you think, data aggregation and the collection of data is going to help pinpoint some of those patients? Because even in surgeons' hands, you brought it up, the same technology in 2 or 3 different surgeons' hands are going to operate a little bit differently with that technology. Do you think data will be able to play a better role as we get to collect and aggregate more data for that?
What you haven't asked me about yet, Brady, is artificial intelligence. And it sounds funny, but that will come more and more into play because we'll have so much data that we can't sift through it. And even if we can sift through it, we don't know what questions to ask. And AI, I think, has a promise in answering that question you just asked.
So as a researcher, how excited are you?
That's what I was just going to ask. Yeah, that's a great thread.
I think it's going to be great. I mean, I've given talks about it. It's combing through the data and then knowing what the question is, because sometimes I don't even know what question to ask.
Yeah.
We have new technologies that'll bring up new questions, but somebody has to think of what the question is. It's not just, as you asked me before, well, what's your pain score today? There might be other questions like, how does this affect your ability to play with your kids or whatever it is. I think there's artificial intelligence will really, really help in that regard.
What do you think also about, the individualization of care based on using AI? Do you think that's going to help us as well, of saying, like, based on you and what we see, like, what is the best treatment possible?
I absolutely think it'll help. I mean, artificial intelligence might say that for this 25-year-old patient who has this cholesterol level and this disc height, and I'm making these things up as I go along, that this is the operation that's going to be best for you.
I think that's exciting.
It is exciting.
It's scary too, right?
Scary.
Like, it's a little scary, but using it, for good in situations like that, where we can just even better hone in on what is right for a patient. And to your point, it might say you shouldn't get surgery at all.
Right.
I think that is also something that can ease your mind as a patient, because there's a lot of fear going into surgery. I'm sure you experience this with patients. Like, there's fear around getting on that table.
Sure, especially spine surgery.
Yeah.
I think one of the things that, we talk about expanding indications for spine surgery. Should we do surgery earlier? If you're an insurance company, you're going to be very concerned about that, right? Because all of a sudden, there's only a fixed bucket that you can offer. And if all of a sudden you're going to say, well, I'm going to operate on more people, hypothetically, then that's a problem if you're an insurance carrier, because you have to figure out who you're going to offer this to. But you might have devices or a new innovation that says, you know what? There's actually less patients that need this operation, or we should do this later, or we should do it sooner. Or if we do this operation, after patients failed non-operative treatment, then maybe 12 months of non-operative treatment is too much. Maybe it should be 10 months of non-operative treatment, and you're saving in hundreds or thousands of patients 2 months of cost of physical therapy. I mean, those are all questions that we need the answer to. If you're only looking at one bucket, then you're missing the opportunity to see the savings in the other buckets.
We obviously love the work that you do in motion preservation and how much you've done to push that field forward. And we talked a lot about a lot of general concepts, but I think this feeling of, leadership and teaching and clinical education, it reigns very strong with you. I think it's absolutely incredible. You're a professor here at NYU of orthopedic and neurosurgery at the Grossman School of Medicine. Did you know that teaching was always going to be part of what you wanted to do, or was that an interest of yours when you started on this journey, or did that come over time?
I think it's a matter of being inquisitive. I learn a lot from the people around me. So by asking questions, we have a great spine fellowship, and quite frankly, I learn more from my fellows. They, and it's just by asking a lot of questions and trying to find the right answers, whether it's through research or group education. We recently had the opportunity to get all of the spine surgeons in Manhattan into one room for a discussion. Some of the finest institutions in the country for spine are here in New York City, and there's obviously strong institutions throughout the country and throughout the world. But to get all of those great minds and great personalities in one room is an opportunity that to really learn and learn from each other and bounce ideas off each other. And that's where I think the benefits of this kind of interaction come from.
You were a lead individual in getting that set up, right? The New York Spine Society. And if I'm not wrong, that was like, what, 3 or 4 days ago was your inaugural meeting? I could be wrong, but I believe this just happened.
You're reading social media too much.
We try and stay on top of it, yes.
But what was that like? What was that room like? I can only imagine the energy because like you said, like New York is kind of like the top of the top when you think about a lot of things, but in healthcare, it's also a place that people will fly out to see you, to come to NYU. What was it like to be in a room with kind of like, the cream of the crop?
I've thought about this for many years. COVID came and it sort of fell to the wayside. I learned so much from my peers that to get everybody in the same room was an awesome opportunity. I look forward to expanding it because, once again, to have such, great personalities and smart folks in the same room, there's only positives that can come out of that. So it was very fulfilling, and I think folks were happy to do it. So I look forward to doing it again.
It's awesome.
Yeah, and so what was the driving factor in setting that up for the New York Spine Society? Because one, you've had leadership positions in other societies, and you've won paper awards. You've done everything, right? You're members of all the societies. Why start that here in New York for a New York Spine Society?
And when do you sleep?
Not as much as I should. For as long as I've been in practice, I've had patients that have seen some of my colleagues at other places for second opinions. I've had patients that sometimes maybe won't do as well as I hope they would do, where they go to see other colleagues for second opinions. And the same holds true, that I'll see my colleagues' patients for second opinions. And I'll see how they did the surgery or how I'm doing the surgery and vice versa. I learn a lot just by hearing what they've told patients to do that might be different than what I told them to do. It's not, they can be things from like Dr. Goldstein saying you shouldn't have surgery, I'm saying you should, or vice versa, or I'm saying you should do a fusion, or you're not a great patient for motion preservation. But all of these folks are, I really enjoy hearing what they have to say. So I thought it would be a great opportunity to get everybody in the same room and, put the face with the name. Unfortunately, a lot of these folks I see only outside of the city because we're so busy taking care of our patients. But once we go to a conference outside of the city, you're in a room with them. So you're interacting, and they're not getting home to see their family, unfortunately, but they're with you, and you have the opportunity to get to know each other. And quite frankly, I enjoy being with them and hearing what they have to say, and I hope the feeling's mutual. So I think it was got a lot of great feedback. I look forward to doing it again. And, and in the interim, I invite the professors from the other institutions in New York and quite frankly from around the U.S. and around the world to give lectures here. And that's how we learn. So to me, it's very exciting. And I always want to hear new ideas. Or have somebody tell me why what I'm thinking maybe not is the best idea.
Well, that's how we move forward, right?
Exactly.
And silos can be so cancerous in that way. And like, I think bringing people together, especially we're in this like very big inflection point in spine with so much innovation happening, like all of the enabling technologies that you talked about, the motion preservation devices that are coming, how AI is going to come into play, having those kinds of conversations and conferences and societies so everyone can kind of talk about it and be able to see all the perspectives, I think is very, very important right now with where we are.
You just have to be open to it. I mean, I think that the most discouraging thing that I see, and don't see it often, is somebody who just wants to stick their head in the sand. And listen, if you're good at what you do and you get good results, then that's fine. But it's discouraging for me not to. If you're that good, why not share what you're doing so I can learn from it, or be open to new ideas and try to move it forward? Because there's, as good as we are, you can always be better.
This is one of the things we love about you is your commitment to improving patient care and getting new technologies out there, right? Because you made the point earlier, you can have really, really good technologies, and if they're not trained correctly or if they don't fall into the right hands, right? I mean, they won't make it to the market, and there's a lot of reasons for that. So we need the right people training. We need the right people doing all these things to move it forward.
That's true with any new technology. If you talked about training, for the other devices I've been involved in, if you come up with a great idea and I can do it, that's great. But if I put it in the hands of somebody else and they don't have the opportunity to be properly trained on it, then you're not going to get the results that your patient's not going to have the results that they deserve to have. And that's where training comes into play.
Absolutely. It's so important. I mean, we've seen this. We've seen products go off the market for it. And we've seen products launch really well because of really good training and folks like yourself who are willing to do that. Courtney made a great point too. You being here in New York City, one of the most populated areas. You could argue one of the most hyper competitive areas for not just spine, but medical care in the U.S. And you're at the top of the food chain. Whether you're in leadership roles, you are seen as a mentor. You are very highly regarded here. And so you're not just cutting your teeth down here. You have made it here in New York, and you have an unbelievable practice and all of this. One of the questions I have for you is, why here? Why NYU? Why have you've been here 30 years? Obviously, you like it and you've done very, very well. But why? What's made you stick around?
As I mentioned earlier, I had never had any intention of coming to New York City. I came here. There's a camaraderie with the people I've worked with. There are surgeons I've worked with from day one that are here. There are surgeons that I trained who are here. There are surgeons at other institutions that are here. As much as it's competitive, it's very collegial. And my patients have been happy. If I have a patient goes to another institution to get another opinion and they come back, I'm very happy with that. If they decide that it's a better fit for them somewhere else, the patient has to do what's in their best interest. But, I think the fact it's motivating and exciting for me to have patients, most importantly, we're here for our patients, so our patients have good, safe results. But also to work with folks who are as excited about it as I am. And it's true in New York. It's true throughout the country. I mean, whether it's in another big city, like Chicago or LA, or whether it's in a small community or regional hospital.
It's incredible because we talk about this a lot. It takes a team, right?
Yes.
And you can say, I'm surrounded by all these great people, and that's great. But the truth of the matter is you set who you're surrounded by, right? That happens in your family, that happens in your professional life. And so you're able to create this team that is able to provide better care and talk about new technologies and do that. And that's how we advance spine care, right? I mean, that's because of that, not because of the other side of the spectrum, right? Which is this hyper competitive kind of side.
And you're setting that pace, really, as a leader, even just with being the PI of MOTUS, you are constantly the one at the front setting that pace and setting the expectation. And also, I feel like opening your arms of let's learn together.
Well, I think a lot of it is you have to be confident in yourself that you've done the right things, you've read the right articles, you've done the right training. And you have to have confidence in the people that you work with. I mean, I strongly believe that a rising tide floats all boats. So, I want to work with people who are excited to do what they're doing. I want to work with people who want to contribute. Everybody contributes in their own way. The only people I don't want to work with are people who want to tear it down. So, there's an opportunity in New York. It's a big empire. You can expand your empire by working with other folks who also want to, have the same philosophy and same approach, who want to help people. Not everybody has to wake up every morning and say, I want to start this course or that course, but they at least want to contribute in whatever way is best for them.
It's one of our favorite sayings, a rising tide floats all boats. And those are the folks, when we were sitting down here having these conversations, that there's a reason that we're here today with you.
Yeah.
And it's because of things like that,
Yep.
right? You want to push the ball forward. You want to be surrounded by the right people. You've obviously been a contributor, right? Hundreds of publications and podium presentations. I mean, it's been impressive, the work that you've done. As we talk about this, we talked about all these different technologies and, what's coming to market. What has you most excited for, the rest of your career? What's next on your career and what you're excited to push forward and help move forward?
I'm smiling because I think my wife asked me that too.
And is her answer different?
She said, you need to get a hobby. I said, when do I have time? But, as I tell my fellows, it's family first. So it's my patients and family first. So those are the things that excite me right now. And, thank God they're both moving in the right direction. So.
I mean, you can't do it without that, right?
Yeah.
Without a family that supports you and a wife, and it's unbelievable. We hear those same stories that you couldn't do it without that.
I mean, you have to be happy with what you're doing. You have to be excited by what you're doing. You have to be around people who appreciate that, who are, working with you. If you're in a group of people who have no interest in helping you or only want to help themselves by pushing you down, that's a bad situation. And I haven't seen that in New York. So I'm at least not where I've been. I mean, NYU Langone has been a place that's really fostered innovation, been very supportive, very strong on looking at quality for our patients. looking on costs. We talked about insurers and making sure that society can afford this. They've done the right things for people, and it's good to be part of the team. So that's kind of what keeps you coming back. And plus, I like the people I work with, and that makes a big difference.
So I want to finish up by talking, directly to patients. For patients that are looking for this, I think it can get really confusing sometimes going through the care continuum and knowing when you're supposed to go where or when it's time for surgical intervention. If you're giving advice to patients, when is it time to go see a spine surgeon?
That's a really good point, Brady. A spine surgeon is probably, in most cases, not the first person you want to see. As I mentioned before, typically patients have back pain. It's going to go away. You can see your internist or your primary physician, and they can get the ball rolling. By the time, most of the patients that I see, the best experience for my patients is when they come to me. They've had non-operative treatment. They have their imaging, like an MRI, potentially X-rays, and their pain management, and they're looking for a surgical solution. But when a patient comes to me and they've said, listen, I woke up with back pain yesterday, it's like I'm going to most likely give them some physical therapy, and it's obviously different for each patient, but you'll have a better experience if you've gone through the non-operative stages first.
And let's say you're a patient and you've now exhausted your non-operative care, right? You've gone through your conservative care timeline. If a patient was coming to you, what is it that you offer here at NYU that a patient would be looking for? What is it that patients look for? We've talked about navigation and robotics and MIS surgery. What is it that some of the technologies that you guys provide here?
First of all, in addition to that, the surgeons here have had a lot of experience. We take care of a lot of patients, and I think our surgical results have been good. We can offer our patients, when appropriate, surgical options, which can be anything from less invasive surgery, minimally invasive surgery, complex spine surgery, and then new technology, whether it be robotics, artificial disc replacement, navigation. And those are the things that can really help the patient who needs surgery have a better surgical experience, in my opinion.
I think what's also great about NYU is you are involved in clinical trials. So you also have options that maybe you wouldn't be able to get other places if you think someone's a good option for something that's still, is in a trial, and the potential there as well.
In addition to that, Courtney, this is a big hospital. It's a newer hospital, and it's a team. Obviously, when a patient comes in, they're coming to see me as their surgeon, but I have scrub techs, scrub nurses, anesthesiologists, nurses on the floor, nurse practitioners in our clinic. They're all part of the team. This is the team that's going to take care of you. This is the team that's going to answer your questions, and this is what's going to make you feel satisfied and happy that you had a good experience at NYU Langone.
Yeah.
And I want patients to know too, even if you're not in this local area in New York City, you have patients that are traveling to see you as well. Sure.
I've had patients that fly from across the country. They come in for surgery and they leave, sometimes the next day, oftentimes, in a very short period of time. I've had patients who come up from Florida or from California. It's it's not difficult for patients to get here.
Not a bad place to come get surgery.
It's not a bad place
Maybe
to get
see
surgery.
a show or two before or after surgery. Make it a whole trip.
I like the way you think.
Well, it's a testament to the person that you are. It's a testament to the surgeon that you are. Being able to build the practice that you have in this area and have patients travel. Patients don't travel to get care if they're not getting a higher level of care, right? So it is a true testament to the level of care that you're providing, to the outcomes that you're having, and it's incredible. And obviously you have all these accolades, and we've talked about that. You've won paper awards, and you've been named top doctor across New York City and nationally. One thing that I want to make sure that we note on as well is I believe you were inducted into the Islip High School Hall of Fame. Is that true as well?
The first inductee.
I don't want to breeze past the most important point here.
I didn't know we were around royalty. Oh my gosh.
Exactly right.
I just got shy all of a sudden.
Go Buccaneers.
No, it's fantastic. We have so much admiration for you. We have so much respect for you, for the work that you've done for patient care, for the spine community. And we're really fortunate to get to know you over the past few years and everything that you've done. And we're excited to see what's to come here.
It's a privilege to have you guys come and talk to me. I can go on and talk for a long time, so maybe that's why you're here. But it's a privilege to take care of patients and to innovate and provide new technology. And quite frankly, at the end of the day, have a patient come back and say thank you. So I consider it a privilege and an honor, and I've worked with some great people here, and look forward to continuing in that lane.
To wrap it up, where can those patients that are going to be so eager to see you find you? What's the best way to contact you?
Probably my website, which is spinesurgerydoctor.com.
Amazing.
Yeah, I was going to say that was as clear as anybody said it so far. So it's incredible. Well, we appreciate it. Obviously, patients are going to hear from you, and this is not the last time we're going to see you. We're going to see you on podiums. We're going to see you on publications, and we're really excited for everything to come in the future.
Well, thanks, Brady. Thanks, Courtney. And thanks to your patients for listening.
Absolutely. Thanks so much, Dr. Goldstein.
Thank you.
Sure.